Good morning, early birds to Eggheads. This is Michelle from the Colorado Health Institute. We have a few minutes before we'll dive into this month's Minding What Matters, but thanks for joining us today. We'll wait for a few others to grab their coffee and join us here. All right, good morning. We're just a minute or two so others can hop on the call with us. I see that we're still piling into the Zoom participants list, and so we'll give everyone another minute or so before we get going here. It's good to see so many faces or names of people I know faces of, so thanks for joining. All right, and while we're waiting for those last few people to join us here this morning, just a few housekeeping notes before we get started. The best way to see the presentation is to change your Zoom to speaker view. It's in the top right-hand corner of your screen. I'm sure we're all familiar with that now that we're 2 years into this hybrid environment. We'll leave time at the end of this discussion today for your questions. But anywhere along the lines, feel free to drop them into the Q&A, and we'll make sure that we get to as many as we can. So with that, I think I'm going to kick things off here at 8:01 because we've got a lot to cover with all of you here today. I'd like to officially welcome you to the Colorado Health Institute's March Egghead session, Minding What Matters. We're going to spend the next hour taking stock of Colorado's investments in behavioral health. My name is Michelle Leek. I'm the president of the Colorado Health Institute, and I'm delighted to be joined today by my colleague, Alex Caldwell. She's a director here at CHI, and one of her hats is that she's the leader of our behavioral health portfolio. So welcome to all of you, and Alex, thanks for joining me. I recognize a lot of the names on the call today. So for those of you who know me and I know you, welcome. It's good to see you. For others, welcome to CHI and this Egghead session. As a brief introduction, the Colorado Health Institute is an organization found on a simple belief that good health policy leads to a healthier Colorado. Every day, we bring research, insight, and expertise to leaders across the state because we firmly believe that informed decisions lead to better health policies for all. As you know, I'm always welcome to talk to you about how CHI can help you and your organization. Reach out to me. You know how to do it. I look forward to hearing from you. Today, I'd like to share some emerging ideas that we have percolating here on the CHI team. First, I want to share a little bit about our 20th birthday celebration here at CHI. Second, we'd like to spend some time making sense of the behavioral health landscape. I'd like to share with you what would be the narrative arcs or themes if we were to think back on the last 10 years, or if we were to kind of make a movie about it, what would we say about our behavioral health journey? I have some ideas about that, but be forewarned, I'm going to ask for your ideas as well. Third, Alex is going to take a deeper dive. Not only what are the stories that we can tell, but what are the lessons that we should extract from the last decade of really big investments, significant investments in behavioral health? What are the lessons that we as a community should take with us as we move forward into the next decade? And finally, I'd like to share a little bit about CHI's intended role as we look forward to the next 5 or 10 years, and how we imagine and hope to be in partnership with all of you on this line as we tackle the challenges of behavioral health. As I mentioned, 2022 is a milestone year for CHI. Next slide, please. So rather than saying happy birthday to us, we'll celebrate with you at some future time. But the team here has given a lot of thought to what CHI's impact has been over the last 20 years and what this means for where we are moving forward. We have been honored to serve in so many aspects of health and healthcare policy and program development, but we have always remained true to our mission of working to make Colorado a healthier place. For some of you historians out there, I think of our first decade as largely focused on improving access to care. Our second decade really focused on expanding our definitions of both health and policy to include social and economic drivers of health. And health equity has always and will continue to play be a significant value in our work. It's paramount to all that we do. We are proud of our last 20 years, and many of you can join in to celebrate the progress that we all have made here in Colorado. And we'll explore some of that as it relates to behavioral health today. At this milestone, next slide, we have also taken a hard look at where we're headed. What does our 20 years of experience of supporting the policymakers, state leaders, and local communities, what does all of that tell us about where we're headed? Where are we headed as a state, which I'll get to in just a minute, and as an organization? And for CHI, we've landed on, for the next 5 to 10 years, to bringing more intentional focus to 3 aspects of our health that are pressing and urgent priorities for all of us over the next decade. In our estimation, we have a short amount of time to get these right. So you'll see, coming from the CHI website and other ways of dissemination, you'll see a sharper focus as we turn to climate and health, systems of care, and behavioral health, as we'll explore today. We've come to these focus areas based upon our cumulative insights about the health of our state, the research we have done in partnership with many of you, and our continued analyses of the legislative, executive, philanthropic, and advocacy work that all of you represent. Our longtime emphasis on equity shines an important and meaningful light on these issues. And without intentionality of really centering on equity, I fear that we are poised to enhance inequities and not mitigate them. We only need to look to the last 2 years of the COVID epidemic to realize this caution. If we are not wise and deliberate about how we dive in, I fear recreating past inequities. And it's our task, our challenge, not only at CHI, but with the entire policy community to change that. We've decided to kick off this health agenda with a dive into an exploration into behavioral health. Next slide. And a kickoff might seem like a bit of a stretch because we have arrived at this point of investing more heavily in behavioral health based upon a decade's worth of work. And that work could be characterized, at least from CHI, is how do we get to better systems, better care, and better behavioral health outcomes for all of us. Just to name a few partners that we have had over those years, we have worked closely with the Office of Behavioral Health, the Department of Healthcare Policy and Financing, the Division of Insurance, the Behavioral Health Task Force, the Denver Foundation, and the Colorado Consortium, Partners for Children's Mental Health, and Mental Health Colorado. Those are just a few of the organizations we've had the honor to work with. But this has given us a unique vantage point to support and drive our behavioral health agenda, and I mean everyone's behavioral health agenda, as Colorado dives in deep on this urgent health crisis. We come to this focus area steeped in experience and research. Let's see. So part of what we do here at CHI, if you've attended some of our annual conferences like Hot Issues in Health, is that we often sort of look from the balcony. We try and provide to make sense and provide a certain kind of context of what we do in various policy areas. I know if you're like me, we can get mired in the day-to-day. We can be thinking very specifically about a bill that we want to have passed or implementing a particular program. And I often ask my team to lift their gaze. So I thought I might offer sort of a collective look and as looking from the balcony and provide a lifted gaze to all of you here today. If we were to take a look, if we did a 10-year look back, even at just the legislative level, over the past decade, the work that we've done can be dizzying. If we just selected the highlights, for example, over the last 10 years, our journey or our story might look like this. In 2013, not only did we expand Medicaid, but we recreated the behavioral health crisis response system. Following in 2014, the state innovation model allowed us to really explore in size and scale behavioral health and physical health integration. And we began to direct marijuana revenue. Remember that when we got it legalized, we began to direct some of that revenue to youth and prevention and treatment. In 2015, we doubled down and expanded our workforce but in the behavioral health domain for minors. And in 2016, we made legislative investments in suicide prevention and the expansion of substance use disorder services across the state. In 2017, we ended the practice of treating those with mental health illness and crises in jail. And in 2018, we saw the passage of the Medicaid residential treatment benefit for substance use disorder. 2019 brought a flurry of activity around parity, not only in Medicaid for behavioral and physical health, but also in our commercial markets. And we, at the same time, improved treatment options for opioid and substance use disorder. In 2020, we saw the fruition of the governor's task force on behavioral health and the creation of a blueprint for us to move forward. And in 2021, we saw the implementation of one of those recommendations with the creation of the Behavioral Health Administration. And today, as we await, I think even this week, we're awaiting to see more details, more refinement, and more funding and the governance around the Behavioral Health Administration. And we're also seeing key legislative bills, particularly on kids and families and where they intersect with communities, schools, and clinical settings to improve behavioral health services. These, I should share, are just the headlines of behavioral health developments. Underneath are dozens of other bills, of rule changes, of executive orders that furthered our work in behavioral health. And that's not to say anything, or not to mention the task forces on behavioral health and opioid dollars, COVID relief funds, affordability, and more. Advocacy organizations, school district meetings, local public health agencies have all had their hands and fingers in the pot of improving behavioral health services. The work has been impressive. But how do we make sense of all of this? How do we get from the dizzying view of all that we have passed? So I asked myself, if we were movie directors, how would we describe thematically the work of the last decades? What kinds of stories or narrative arcs would we overlay over all the actions and activities of the last 10 years? And in true CHI fashion, I'm going to offer you 5 storylines. But that's not all. I'd like for you to be thinking of your own storylines. How would you characterize the last decades of our efforts? Because I'm going to ask you at the end of my 5th. First off, we might have a storyline about pursuing integration. Programs like the State Innovation Model allowed us to dive into integrating physical and behavioral health in meaningful ways and at scale. We saw the repercussions of this emphasis on integration in both enhanced Medicaid benefits, especially for kids receiving behavioral health sessions in the primary care setting, and an emphasis on the development of the regional accountable entities, the Medicaid medical homes, structuring those and so that there is a more finely attuned relationship between physical and behavioral health. Storyline number 2 might be that we've elevated priority settings. Jails, crisis centers, schools, and childcare settings all have benefited from greater resources, attention, and attention over the past decade. We have sought to address behavioral health needs in these priority settings. And I think this concept of priority settings, those places where people with behavioral health needs, where their needs are often acute, and they're places where they intersect with community and systems, I see these priority settings as being increasingly important in terms of our policy and advocacy work in improving behavioral health. We've seen positive changes, for example, in the laws around where people in crisis can get help that's not a jail. And we've seen emphasis on things like diversion programs, crisis center calls, and co-responders. We are trying hard to get those hard to get those with mental health issues into the right places for care. We've seen investment in schools, a key place to interact with our youngest and often most susceptible populations, from getting school counselors in every school to targeting marijuana revenue to education, prevention, and treatment. And childcare, like the work that we've done with the PDG grant on Shines Brighter and other OEC programs that have focused on bringing early childhood mental health consultations to more and more families. These are just a few examples of how we have invested in priority settings. Our third story might be one of expanding benefits in behavioral health. We've seen lots of developments in this narrative arc as well. The Division of Insurance, especially under the last 2 gubernatorial administrations, has emphasized parity laws, strengthening what's on the books, adding to that, and enforcing them. We've seen strides in mandating coverage of behavioral health services, not only in the public sector, but the private sector, the commercial market as well. Telehealth parity has also made marked improvements in access to behavioral health. And I'd be remiss if I didn't note how the Department of Healthcare Policy and Financing has actively expanded substance use disorder residential treatment and other inpatient benefits. A fourth storyline that I offer to you is one about coalescing around the opioid epidemic. We have seen the writing, unfortunately, on the walls of the onslaught of the opioid epidemic and its real-time impact on our state, not only in terms of the relentless increase in overdose deaths, but the devastating impact on families, friends that are left behind. The good news is that we have carefully planned for anticipated opioid settlement funding through the Colorado Opioid Crisis Response Blueprint. We've tackled these issues in Polis's Behavioral Health Task Force, and we've created a plan for substance use disorder recovery across the state. We have also built a notable advocacy infrastructure spearheaded by the Colorado Coalition for Prescription Drug Prevention that continues to steward the importance of righting this horrible wrong. Finally, my fifth storyline to share with you today is that we are naming the deep problems that we are encountering in terms of not only the opioid epidemic, which has unfortunately been with us long before the pandemic, but other related but distinct threats to our youth. I firmly believe that we find solutions to problems once we name them and label them as problems. And Colorado is working hard to address the state of emergency around youth mental health. Children's Hospital in May of 2021 declared this state of emergency for the state and brought our attention to this. This was emphasized late in the year by U.S. Surgeon General Dr. Vivek Murthy, who alerted us to the problem. And I note that he writes in his opening to the advisory he issued that our obligation is not just medical, it's also moral. Those words really resonate with me. So those would be the 5 storylines of my movie that I would make about our behavioral health journey over the last 10 years. I'm going to pause right here to ask you to put into the chat what your storylines would be if you reflect back on the last 10 years. Christy, I'm going to ask you to share with me what you're seeing in the chat, and let's add to the storylines and the movie that we would develop here.
Absolutely. As our budding movie directors get their comments ready here, I do want to add that when you're writing in the chat, please make sure that you're posting to everyone. This way, the whole group and not just our panelists will see your comments. And at least in this moment, we've got a quiet group this morning.
All right. Well, I will leave all the movie directing to me, but if you have anything to add, please do so in the chat. And I will move on to, while we can
now they're coming in.
Oh, okay, great. What do we have?
What is the role of social media? How does public health plug in there?
All right.
All right, got another one from Emma Goforth. She notes that stigma is decreasing, but we have a long way to go to reduce stigma.
All right, so we have like a stigma and a social media line here.
All right, Doug McCarthy's telling us strengthening local collaborative management programs and intensive in-home family counseling programs to help youth remain in the community.
Great. So this is the idea of expanding our front line of workers and including socialized responses. Terrific. Yep, and place-based work. Well, keep those coming in. We're very interested in your storylines, the narrative arc of our last 10 years. And before I turn things over to my colleague, Alex, I want to just turn to we can spend a lot of time sort of celebrating the improvements and the marked investments that we have made in behavioral health. But I also think it's important that we take stock about whether or not all the work that we have done Well, honestly, is it enough? And I would submit to you that it's not nearly enough at all. This is a slide that I am not happy to share with you, but I think it's sobering news and things that we need to take into account. Overdose deaths continue to stubbornly be on the rise. Colorado Public Radio just last week reported on the increase in fentanyl deaths and how that's escalated during the pandemic. Our suicide rate remains stubbornly high, especially as a leading cause of death among some of our youngest populations. We still continue to struggle with access to clinical behavioral health experts. And the counties that this is just one indication of it, but the counties that don't even have one practicing psychologist has increased over the last decade rather than decrease. And finally, just suggest to you that there's been a lot of time, or there's been a lot of attention recently paid to sort of the skills that have been lost as a result of kids not being in school during the pandemic. The average months of learning lost compared with typical in-classroom learning in 2020, we see inequities surface between white and Black students. But we also need to think not just about what's lost in terms of reading, writing, and math. We also have to think about social, emotional issues that have just not been developed because of this lack of immediacy or lack of in-person learning. There will not only be an academic repercussion to this lost time in the classroom, there will be social, emotional, and behavioral issues associated with that at all. And we don't have to look to things that are necessarily particularly acute or making headlines. The CHAS and the Colorado Health Access Survey, which many of you know is a hallmark of the work at CHI, we ask Coloradans like you and me, how many days of poor mental health have you experienced in the last month? And we track the number of people who have more than 8 days, who tell us that they have more than 8 days of poor mental health. In 2017, about 10% of us reported in that way. As in 2019, that grew to 15%. But the most sobering of all is that in 2021, almost 1 in 4 of us now report having over 8 days of poor mental health. There is work still to be done. And it's hard not to feel dismayed or defeated by this. The challenge is enormous and complex. But I want to leave you on a different frame, one of optimism, that the work we have done, the seeds that we have planted, are ready to be sown. The details of the Behavioral Health Administration implemented last year, and looking for details even this week, we look forward to that sort of focus on behavioral health. We're also anticipating the realization of lots of funding coming from the American Rescue Plan and the CARES Act, the Coronavirus Aid, Relief, and Economic Security Act. We're anticipating those flowing to the state. So I challenge all of us to think of the next few years as not with a scarcity mindset, but with an abundance and focused mindset. I'm optimistic that our fruits, where we've invested, will make a difference. I have focused on the movies and the storylines of the past decades. They also come with lessons learned. And as we look forward, looking to the work in front of us, my colleague Alex is going to share with you some of the lessons that we can take from the last 10 years to apply to the work moving forward. So with that, Alex, I turn the virtual mic over to you, and I thank everyone for their time this morning.
Thanks, Michelle. Good morning, everybody. Happy Eggheads. It's really nice to see so many familiar faces. I'm Alex Caldwell. I'm one of the directors at the Colorado Health Institute. I've been directing our behavioral health research for the last almost 6 years. So I'm really eager to share with you a couple of thoughts this morning. So what Michelle just shared, that's our look back. that's our look back to the 5 storylines from the last 10 years or so of Colorado's behavioral health transformation. And we at CHI believe that there's some real wisdom to gain from those storylines. And so our question today is, what are the lessons we can take from those storylines to inform what we do next to make sure that our behavioral health system allows every child, every young person, every family to thrive in Colorado? So we spent the last few months reviewing our contributions to the field of behavioral health, and based on that, like meta-analysis, I want to offer the following lessons that we believe can shape our work collectively going forward. So here they are. Number 1, implementation is the new innovation. Representation matters. Want results? Get focused. We can't workforce our way out. And finally, the front line is us. Number 6, we'll have a bonus lesson. These are intentionally provocative. We want to get your thoughts. I would really encourage folks, I love the comments we just got on in the chat. I'd encourage you to use the chat, and I'd encourage you to use the Q&A. We'll have some time at the end to just reflect a little bit collectively on, are these the right lessons? What would you add? We're eager to hear from you. Let's dive in. What do I mean when I suggest that implementation is the new innovation? This is a quote from Dr. Thomas Insel. He's the former director of the National Institute of Mental Health. Here he is quoted by the New York Times. "We could continue doing research until I'm in my 90s, but if we can't get this stuff actually implemented, if people aren't doing it, what is the point?" So to improve our mental health, Insel argues that innovation, for example, in brain research or new programs, it's helpful, but we already know how to improve mental health. The problem that he cites is that implementation is, number 1, less glamorous than cutting edge research and innovation, and 2, it requires political will. I am heartened to think that the formation of Colorado's first behavioral health administration is an expression of some of Colorado's political will that we need to improve mental health. And in recent years, CHI has supported programs that work. What these programs need now is implementation at scale. A few examples. We learned in our work with OBH and the Office of Early Childhood that delivering programs to families, like Parents as Teachers, Nurse-Family Partnership, these programs strengthen protective factors like parental resilience and social emotional health for children. For example, compared to similar low-income groups, babies of moms that participate in Nurse-Family Partnership, NFP, are half as likely to experience behavioral health or intellectual problems by age 6. And they're also half as likely to get involved in the justice system by the time they're a teenager. We also know that programs like assertive community treatment teams that provide on-site therapies in community, in homes, are proven to reduce hospitalization, and they're proven to reduce the burden of severe mental illness more than if we were to rely on outpatient services alone, as important as those services are. These are tried and true programs, and we believe that the next step is to implement. So I'd encourage us to keep that in mind in the coming years of policy development and resource allocation. Michelle mentioned earlier that we must be intensely focused on health equity in all we do. The first thing that we believe we need is we must build a more racially, linguistically representative workforce of behavioral health care providers. Today, while almost half of our nation identifies as a person of color, fewer than 1 of 5 psychologists do. And according to the American Psychological Association, only 3% of our psychologists identify as Black or African American. That matters when it comes to behavioral health. Shared identity matters. Shared language matters. For example, from the 2021 CHAS, the Colorado Health Access Survey, only 19% of Coloradans who speak Spanish at home had a mental health care visit in the last year. That's compared with 28% for those who speak English at home. There are probably a couple things going on there, but one major factor is likely the fact that many of our providers do not speak the languages that their patients speak. We in Colorado understand that the diversity of our workforce matters when it comes to outcomes. And we're investing in a more diverse workforce. It's happening across the board. For example, in specific programs. One example is the ALMA program run out of Valley Settlement. It's a peer support program that promotes mental health of new mothers by pairing women with trained peer navigators who speak the same language and have shared behavioral health challenges in their own lives. And that diversification is also happening at the systems level. For example, the Behavioral Health Administration has placed health equity at its core. The law creating the BHA, for example, mandates the BHA to do a number of things, and one of its core reasons for existence is to diversify our behavioral health workforce. We also applaud the BHA's creation of the College for Behavioral Health Leadership's Equity Grounded Leadership Fellow Program. We look forward to supporting their work on unraveling systemic racism and building equitable behavioral health systems in their communities. Third, CHI has seen over and over again that focused attention brings desired results. One example of this lesson is our work evaluating the Denver Foundation's Colorado Health Access Fund. The report is pictured here. The fund focused $20 million on priority populations, and it brought behavioral health services to more than 100,000 Coloradans since 2016. And I'd argue that it did this by focusing. It focused more than a third of its funding on rural communities. It focused most of the program's dollars in programs and organizations that disproportionately serve immigrants, refugees, people of color. It's invested much needed but difficult to scale programs that include things like medication-assisted treatment programs to help address the opioid crisis. And it does that in hard to reach places like in jails, in rural and frontier communities. And as a result of that focus, more than 100,000 people who we believe would otherwise go without mental health care gained access to culturally competent care. What's exciting about this lesson that focused investments bring results is that we're doing that in Colorado. For example, through the BHA, we are focusing our state's behavioral health investments, policies, and programs in one roof. Dr. Ben Miller, many of you know, a trusted colleague of many of us, who's now the president of the Wellbeing Trust, he noted in a recent op-ed in the Colorado Sun that the new Behavioral Health Administration has the potential to bring this kind of focus. He pointed out that under the BHA, this is a group of very disparate resources, disparate stakeholders that are going to come under one shared organization to get life-saving services to people who need them. He says, for the first time ever, a mental health professional, Dr. Medlock in this case, will have a position in a governor's cabinet for the explicit purpose of guiding better mental health policy in the state. As he puts it, this is a one-of-a-kind development. We need to continue to focus our efforts to get the results we want, and we're on our way. Here's your fourth lesson. We can't workforce our way out. I would guess that all of us here today on the call have been to a number of, maybe even dozens of meetings, lamenting the state of the behavioral health workforce. It is dire. We have to acknowledge that. The Colorado Sun recently reported that nearly 20% of our pre-pandemic behavioral health workforce is, quote, missing. And that's just if we're going to get to pre-pandemic levels. That translates into real numbers of Coloradans who are not getting care. CHI estimates that 80,000 Coloradans did not get needed substance use treatment in 2021. Nationally, a third of people seeking behavioral health care wait more than a week to access a clinician. 50% drive more than an hour round trip to get their care, and 50% of counties in the US have no psychiatrist. And so it's no surprise that we are focused on our workforce. And so, of course, we at CHI applaud all of our efforts to do that work. But we believe, based on our experience, that we are not going to workforce our way out of this problem. What we think we need to do is we need to get upstream and address demand. And to do that, we need to execute on our plans. We have a statewide primary prevention plan to prevent substance use disorders in young people. We have a statewide recovery plan to make sure that our systems are oriented to recovery. We have these roadmaps, and now the question is implementation. Remember that lesson number one, implementation is the new innovation? This is the case in point. To that point, lesson number 5, here's your final lesson before our bonus. To really improve behavioral health outcomes, mental health needs to become everyone's business. We need to change the definition of the front line to include us. This is a picture that depicts the U.S. Surgeon General's report on advisory on youth mental health. And I like how vividly it displays this lesson. The report is organized around the idea that behavioral health is everyone's responsibility all the way across this socio-ecological model. It asks, what can we do to promote behavioral health? And it suggests that we is truly all of us. It's family members, it's young people, caregivers, schools, healthcare organizations, and clinicians. But it's also media and entertainment, social media, community, and funders and employers, local, state, and tribal government. It's the federal government. It's a comprehensive list. And while in Colorado we are not quite there yet, we have started down this path. For example, we've trained more than 75,000 Coloradans in mental health first aid. We've also trained peers to address the needs of their communities. One example that comes to mind is the Rocky Mountain Farmers Union. That is one of many organizations that is investing in mental health peers. The Rocky Mountain Farmers Union is training community members to support the behavioral health of farmers and ranchers and their families working in Eastern Colorado's rural and frontier communities. And one of the reasons that that work is so important is that it's happening in areas where behavioral health providers, the workforce, is few and far between, and where stigma is a real barrier to accessing services. It's programs like those that are going to get us to where we need to be. So that's our lesson. Behavioral health requires us. And here is your bonus lesson, one to leave us on a good note, and that is that wellness is possible. Recovery is possible. Vic Vela, pictured here, he's a Colorado Public Radio host, a voice that many of us know. He spoke at Colorado Health Institute's Hot Issues in Health conference a couple of years ago, and that was when he was just a few years into his recovery journey. He's a testament to the fact that recovery is possible. I'll leave it to you to read this powerful tweet that he shares here, but my takeaway is in these last couple of lines, and that's, we can recover, every one of us. So it's hard not to feel defeated by where we are, but we believe that we have what we need to build a system that's going to better serve families in Colorado. So moving forward, we at CHI are thinking hard about how CHI can put these shared lessons to work. And we want to do that in partnership with you all. We want to bring CHI's knowledge and skills and insights to strengthen the state system, but we really want to do that in collaboration with the deep expertise that we have represented here in our state, here in this call. And so we've kind of looked out into the future. What do we see coming? Already we see a lot of these lessons being applied in Colorado, and I'd be eager to hear from the group. We'll have some time today to discuss where you see these being applied or where there's other lessons to highlight. For one, obviously the state's Behavioral Health Administration is a huge transformation for us, but there's also philanthropy. We have some really significant philanthropic leaders in the state. We see big foundations like Caring for Colorado investing in youth mental health and early childhood wellness. We see the Colorado Health Foundation building the evidence base and scaling up programs that work, like innovative substance use disorder programs. And we see Gary Community Ventures surveying what families and kids need and searching for solutions that are going to address those needs. And then, of course, our advocacy leaders, they are raising the voices of Coloradans to address the needs identified through legislature, through rulemaking, and through other policymaking. So we at CHI are working and eager to actively work with you all to support these efforts. Now we're asking ourselves, where do we start? One place that we want to start is by asking and answering some questions about how we allocate resources, because there are so many dollars coming into Colorado right now. These are urgent problems, and we have some resources now to solve them. Where we want to start at CHI is we want to start by analyzing Colorado's adolescent behavioral health system. We want to start by asking, what are our needs? Analyzing the resources available. And we want to ask what works to promote healthy beginnings for young Coloradans. And we expect that work is going to be a call for our state agencies, for our Behavioral Health Administration, to allocate dollars to fill gaps that we identify. And it's also a call for foundations to inform their grant-making strategies. So that's what's on the horizon for us. But of course, we are in this together. Remember that lesson? I think it was number 5. We are all on the front line. We're looking forward to working with you. So I know there's been a couple of comments coming in on the Q&A. I'm really eager to read through those. And I'm going to turn to Michelle to kick us off, or maybe Christy was going to kick us off with some Q&A and comments.
All right, this is Christy. A couple of questions are popping up in the chat, and I'm going to ask Lauren Petralla, if you happen to, if you're still on, can you raise your hand? We'd love to give you a chance to ask your question because it was specific to one of Alex's comments. All right. And now I just have to figure out, Deanna, can you help me unmute Lauren? All right, so sorry. Lauren is asking how you defined academic pressure. I think that was in one of your comments a little bit earlier, Alex. Can you talk about that?
Yeah, Laurel, it's a great question, and I'd be eager to talk with you more about this. I think the academic pressures that we've seen kids experience have only grown with COVID. I mean, that has been so hard to see. I mean, through my own community and through my community of teachers and friends who are academic leaders. And so what we know about behavioral health is that connectedness and having trusted adults in kids' lives do wonders to improve behavioral health and to improve resilience when tough things happens in kids' lives. And so we know that academic pressure is part of that. So I'd be eager to hear more from others who are working in education as to what you're seeing and what solutions there are that we should be thinking about as a policy community.
All right, over in the Q&A, we've got a question from Lynn Jones. Lynn is asking, are efforts being made through the Behavioral Health Task Force and newly coming Behavioral Health Administration to address the behavioral health issues like access, workforce, et cetera, in sync with our efforts in other aspects of the healthcare system, like public health, primary care, school-based services, et cetera?
Yeah. Lynn, I think your question is one right on point about the intersectionality of all of these different issues, right? That we see some fragmentation in the behavioral health system, right? So we have some work going on in the different various silos of government with different philanthropies, with different advocacy organizations. So the hope, I would say, of the Behavioral Health Administration is to sort of hone in, focus our gaze, resources, and allocate our resources in a sort of more prioritized and a more sort of systemic sort of fashion. We're still waiting for details. I think the Sun reported just this week that the financing mechanism for the Behavioral Health Administration, it looks like the dollars are going to flow through the Department of Healthcare Policy and Financing. And there was a little uncertainty, at least late last week, about the number of employees that would actually be had. That's more than the Office of Behavioral Health currently. So those are things that are still underway. But I am, at this point, like optimistic that, to your point, like sort of bringing these resources together and creating some alignment and coordination under sort of one roof, as Dr. Miller suggests, can be a sort of force for good and a force for progress. But the devil is in the detail, and we will wait to see how that shapes up.
All right, I am seeing some comments in the chat related specifically to school-based counseling and therapy. And I'm wondering, Alyssa, can you raise your hand and maybe share your question with the group?
Can you guys hear me?
Now we can, yes.
Hi.
Yeah. So I recently left, as I said in the chat. I was doing health education and physical education for K through 12 for our small rural school here in Gilpin County. And what I saw is a tremendous value in the school-based therapist that we had. But unfortunately, she left due to being overworked because she was the only therapist for a school of 450 kids. And her caseload was huge and she received no support from administration. So there's no school-based therapist now. And I saw the other comment from Lynn about teletherapy, which is I believe, a stopgap. I do not think it can replace the face-to-face counseling at the school. I know many of our students relied on that and it's gone. And I'm struggling now in my new role running our local public health agency on how to assist the school with these. I guess it's a workforce issue, just not having enough therapists to hire, because it doesn't sound like money is the main issue as it used to be.
Yeah. Alyssa, I think your comment is, we hear that often and over again about the decimation of the current workforce and the difficult challenge of replacing that even to the pre-pandemic levels. I'm reminded of a story that was, there was a New York Times Magazine cover story several months ago on what we do about climate change. And the answer was, we do everything. And I think your question really points to the fact that we need to have multifaceted responses to that. As Alex mentioned, like redefining who the front line of the workforce is, which is not helpful news to teachers and librarians and baristas across the state. But I think it's imperative that we begin to think about social, not medical responses to some of our behavioral health needs. I'd also look to some bills and some resources that are making their way through the state legislature, because there are opportunities for communities to apply through House Bill 1281 to sort of build and or invest in local programs. And there's specifically in House Bill 1243 some detail around enhancing the matches between mental health providers and schools. And so I think the legislature is aware of this issue and trying to bring resources to bear on it. It may be up to us to sort of figure out how to capitalize on those opportunities.
Rebecca Rapper had a follow-up question on a very similar topic. I am going to try. Rebecca, you should be able to unmute if you want to ask your question.
Thanks. Hi, Alex. Hi, Michelle. It's Rebecca Rapper.
Hi.
My question is quite similar, which is, we've heard, I think, from partners in the primary care space that they have just lost so much momentum on integrated care during the pandemic. I think because of this workforce challenge and what, should that be a priority for Colorado moving forward to rebuild so much of the work that was done during SIM and other initiatives, or are there maybe new and better ways to do this work? So kind of similar to what you've already addressed.
Yeah. Perennial
Rebecca,
challenge.
Yep.
Alex, you want to take it?
Oh, I just love to hear Rebecca's voice past the entire. Hi, Rebecca. I'll just say, to echo Michelle's comments, I think we've lost a lot of ground since SIM, since the state innovation model. We've seen the benefits of an integrated system, and there's still significant barriers. I'm thinking of the data barriers, the silos that exist just to share across our primary care and our behavioral health data. That is one problem that we just have not addressed. So even if we have co-location, even if we have warm handoffs happening in that primary care space, even when we have the workforce that we need, we still face a number of kind of structural and infrastructure barriers. And I know the Behavioral Health Administration has those issues in their sights. So I'm eager to see what will happen with that and with our data transformation. But on the other hand, there's also been a lot of telehealth adopted during the pandemic, and you still have to have the workforce on the other end of the video screen to make that work. But I do feel somewhat buoyed by the fact that the infrastructure is increasingly there for people to get behavioral health services in a primary care environment due to just having more telehealth infrastructure in place during this pandemic. Thanks for the question.
All right. Mo Keller, looks like you have your hand raised. Do you have a question?
I do, or a question and comment. And good morning, everyone. Thank you for the presentation. I wanted to piggyback on what Alex was talking about. We have seen, we at Mental Health Colorado, where integration and co-location, whatever you want to call it, has been greatly resisted by the private sector. And I had a couple of general practitioners, family docs, who were very, very frustrated because they tried several ways, including hiring their own mental health professional to be on their team, but they can't get them paid for because they're not in the private sector's network, and they don't expand their networks. They keep their networks narrow. I don't know, what can we do on the private sector side to encourage, to enact, preferably, a willingness to have this integrated model, because the SIM model really worked. We had some good data from that showed that the integration of mental and physical health in one visit for folks was very effective. And there are doctors who want to do it, but we've really been stymied by the private sector insurance companies.
Yeah. Mo, I think you raised really good points. It's great to sort of see you again, and thank you for the good work at Mental Health Colorado. I would point to a few things, like what are the levers that we have in the private market, and how you encourage this on the commercial side. One of them is through all the work that you have done over the years on parity laws. I'm wondering if there is some sort of lever that could potentially be used in the coming years to encourage or provide some sort of incentive for that kind of integration that you're talking about. And then, of course, you and I have had this conversation for many, many years about the payment, right? So behavior often follows payment and payment reform. So the more we're looking to the raise as an example of perhaps a place where the public sector can lead the private sector in terms of integration, and the third round of negotiations coming up for the RAY contracts. Those are just some ideas, but I feel your pain on that one. So.
All right, I know we are running out of time, but we have another couple questions in the chat. I will try to get to this one. This is related to the BHA. We got an anonymous attendee who is asking, my biggest concern about the BHA is that it will siphon resources away from direct services to fund its expansive state infrastructure and care coordination services that insurance should actually be paying for. What can we do about this?
Yeah.
I think that this is a perennial question, right? Of the appropriate size of government and the role of government in issues in all sorts of aspects of healthcare. So I think to my reading right now, and is that we're signaling sort of a smaller behavioral health administration, just in terms of like how the dollars are flowing through the health through Medicaid, as well as some uncertainty about how big that department is going to be. I also think the Polis administration is interested in lean kinds of government services, but I also, Ms. Anonymous, I echo your concern about this getting too big and diverting resources where they could really be used in the clinical care setting. So with that, Alex, you want to wrap us up?
Sure. Really nice to see everyone's faces, and we're sorry we can't answer all the questions today, but I have dropped my email here on the slide. And of course, many of you know the other team members you hear and see on the screen. So please do reach out. And I do want to just drop a quick pin for our upcoming Eggheads coming in a couple of weeks. You'll just keep an eye on your email. We're going to be talking about climate change, health, and health equity. We're really eager to share with you some work that we're going to be doing in that space, and we want to hear from you, what you're doing. Thank you again for your time this morning, and we're eager to talk more after today's call. Happy Tuesday.
Thank you.